Welcome
Hi,
everyone to our World Malaria Day event. So thrilled to be here. The organizations and panelists here today are all organized around a common desire to use evidence and reason to figure out how to best contribute to helping others and take action on that basis. And this is the core question of effective altruism, which you would have heard mentioned in some of the previous partner videos there. And it's my privilege to introduce our panelists today and the topic that we have. So, we're here about talking about malaria today. It's actually been a really great 12 months for what has happened here. We've had in November, Cambodia has announced 70% year-on-year reduction in cases. In February, the predicted spike in malaria due to the pandemic was confirmed that didn't materialize, which was really fantastic news. There's exciting stuff happening in the malaria vaccine space, especially related to some of the work that was done on the COVID vaccine. And El Salvador has very recently become the first South American country to be certified malaria-free. And yet there's a huge challenge that still remains. In 2019, there are an estimated 229 million cases of malaria and 409,000 malaria-related deaths in 87 countries. Children under the age of 5 in sub-Saharan Africa continue to account for approximately 2/3 of global deaths from malaria. And the WHO African region shouldered 94% of all malaria cases and deaths worldwide in 2019. So I'm very fortunate that I'm a part of a community here who has been part of doing what we can to try and help the fight against malaria. The Giving What We Can members here today and across the world have been donated close to $9 million to two of the organizations here today, AMF and Malaria Consortium. And that's just one of many organizations here, with One for the World, Give World the Life You Can Save, RAISE, and many effective altruism groups also contributing to help the fight against malaria. And I want to say thank you to all of you. This is an amazing thing to be a part of, and solving one of the biggest problems that the world has seen for affecting a lot of lives continually. But it's not about me. It is about listening to the fantastic panelists we have today. I'd first like to introduce Rob. Rob Mather was inspired to found AMF by a previous charity effort, a 3-person fundraising swim for a 90% burns victim. The effort accidentally developed into 150 swims in 75 countries, including 10,000 people, and raised sufficient funds to secure the Terry's future. He then scaled up this model, starting Against Malaria Foundation with a worldwide swim, which grew to involve 250 people, 1,000 people in 130 countries. AMF has now raised more than $240 million US, 200 million of which has been in the last 4 years, funding 110 million anti-mosquito bed nets and protecting 200 million people in 35 countries, mainly in Africa. Those numbers are just a little bit mind-boggling to get your head around. The Against Malaria Foundation has been consistently ranked a top-ranked charity for Give World the Life You Can Save and Giving What We Can. And it has been a One for the World top pick since their foundation. So I'm going to hand over to Rob, who's going to tell us about AMF.
Thanks very much, Luke. Thanks for the introduction. An update on some of those numbers, surely, because they're a little bit higher, but we'll get to those. You spoke in your introduction about the death toll, the mortality and the morbidity from malaria. And I guess this slide just rounds out that malaria has a huge economic impact on particularly the continent of Africa, because when people are sick, they can't teach, they can't farm, they can't drive, they can't function. And they're therefore not productive members of society. And so if we want to help Africa out of the situation we find it in, then fixing malaria is pretty much at the top of the list. But clearly the humanitarian issue, in a sense, looking at those numbers goes without saying. And unfortunately, there's no vaccine yet. There's no gene-based solution. Maybe there will be in the future. We fervently hope so. But if we focus on just the under 5s that die every day from malaria, 70% of the deaths roughly are children under 5. These numbers are staggering, and sometimes they're difficult for all of us to get our heads around. So perhaps another way of visualizing it, and it struck me when I set up AMF a number of years ago, at that stage it was 7 747s full of children died from malaria every day. And if I invited us all down to the end of our local runway and we saw this happening daily, you know, this is slaughter. So, you know, that helps. It helps, certainly helped me. Perhaps it helps you to put in perspective the, you know, the slaughter that is malaria. If you skip on to the next slide, Luke. Fortunately, most of the malaria-carrying mosquitoes bite between 10 o'clock at night and 2 o'clock in the morning. So in the context of that, a big part of the solution is the long-lasting insecticidal net. In some ways, the humble bed net that costs about $2. And if you have people in affected areas sleeping under those nets, you can thump the malaria-carrying mosquito population, and malaria numbers can decline quite steeply. So it's in a sense one of the things we have on our side. If you move on to the next slide. One of the things that we know about these nets is their impact. There is an awful lot of data that's been collected over many decades now, and you're looking at between 200 to 1,000 nets saves a life and averts 500 to 1,000 cases of malaria, something like that, depending upon the local malaria burden. So the impact is extremely well known. And as the next slide shows, we can gather data that really tells us what goes on when we put nets in place. The black line is number of malaria cases before nets were introduced into a region, and the green line is afterwards. And if you're reducing by tens of % the burden of a disease, you know, across a country, you know, that is quite staggering. And these numbers can be achieved and maintained. So the nets, when distributed, have a terrific impact. If we move on to the next slide, Luke. So what we do as an organization is we distribute nets, and specifically we make sure that they get to the people who need them, and we achieve universal coverage so that the distributions we're involved in we aim for them to be extremely effective. We go to every single household, or our partners do, so that we establish exactly how many nets are needed by each household. Data is checked in a myriad of ways because data sits at the heart of what we do. And we feel that that is the right way of going about using the money that's entrusted to us to make sure that the nets we distribute get to exactly those people who need them in the right quantities. We gather data when we distribute the nets, so after registration of households, and we follow the progress or the coverage of a population in the 3-year period before the next mass distribution will take place. And in a sense, this slide represents a summary, but only the tip of the iceberg, perhaps, of the work we do. But data focused efforts sit at the heart of all our operations. If you skip on, Luke, to the next slide. One of the things that is possible for us to do, even in some of the extremely challenging environments in which we work, is to distribute nets accountably. So one of my favorite images in recent times is this one of the Democratic Republic of Congo that shows within 6 meters the locations of almost 250,000 households that receive nets. So that juxtaposition, if you like, of an incredibly challenging set of environments that we're often working in Africa, and smartphones that can be used to collect data and with GPS information, means that we can use the money extremely wisely to make sure that people are covered, and we limit or remove wastage. If you skip on again, Luke, please, to the next slide. And our work now involves us distributing multiple millions of nets at a time, often a significant proportion of the number of nets needed in the country. And because we're distributing or funding a significant proportion of nets, it means that we have greater success in including, with our work with governments, accountability elements. So very data focused to make sure that we can report back to donors and others exactly what we've done with the money entrusted to us. Next slide, please, Luke. And our progress has really gone in 3 phases at AMF. It's that last phase I've indicated in the last 4 or 5 years where we've been receiving tens of millions of dollars, and that has allowed us to fund many millions, often 10, 15, 20 million nets at a time for particular countries. And the impact of that progress, and when I talk about our progress, I guess. It's not just the staff at AMF, we're a team of 9. It's also the donors, the partners we work with on the ground, people who monitor our progress as well. If we summed it all up and we looked at all of our nets being distributed, so it's not as of today, then the impact is something of the order of 120,000 lives saved, 120 million cases of malaria averted, and something close to 300 million people protected. So it's a, you know, it's a contribution. And if you move on to the next slide, Luke, what we show is where that support comes from. We are not funded by governments, we're funded by the likes of all of us, so private individuals. Most people give us 20 euros or 10 Swiss francs or $30, and that's our bedrock, our lifeblood. No accident that that's colored in red on this graph, which is a cumulative graph of the funds we've raised over time, which now, in fact, just tops $346 million. And occasionally we get some amazing punch the air moment donations that are in the millions of dollar category. And as you can imagine, when we receive $1 million, that buys 500,000 nets, because 100% of that money buys net and protects 1 million people. So it's, you know, it's a fantastic set of donations to receive when they come in, but they only come in because we have, I believe, you know, 100,000 plus donations at a much smaller level. And as I'm at pains to point out often, no amount of money is too small, because every $2 buys a net and protects 2 people. If we skip on to the next slide, Luke. Many opportunities exist right now, unfortunately. Many countries need help, mostly in Africa. And we as an organization are looking at 2 to 20 million nets at a time per country. And we have a 3-year time frame, because there's a significant amount of planning that goes into nationwide distributions. It's not something that can happen within just a few months. If we move on to the next slide, we're almost there. As I finish the introduction of AMF, I would certainly want to inject a note of optimism into what we're talking about tonight. Malaria is absolutely defeatable, fixable. Terrific progress has been made globally by so many partners over the last 15 years. And 2/3 to 3/4 of the reduction in the number of deaths is due to the distribution of the humble bed net. And Luke mentioned El Salvador earlier on being declared malaria free, Sri Lanka the same in 2017, other countries also. So we can eliminate malaria and certainly bring it from a position where it's out of control to being under control in many countries. But that progress has to a certain degree stalled in the last few years. And we're still looking at a child under 5 dying every 60 seconds or 90 seconds. So there's a lot we need to do. You know, we need more money. We need to think carefully about tools that need to be developed. So there are new types of nets being developed now to deal with insecticide resistance. And perhaps in the coming years, we're going to see a significant impact from vaccines and gene drive technology. We all fervently hope so. Thank you.
Thank you so much, Rob. I've been following your work for a number of years. It's just been really fantastic to see how things have been really skyrocketing in the rollouts here. Our next guest is Maddy Marasciulo. As a representative for Malaria Consortium US, Maddy serves as the liaison for Malaria Consortium's partners and donors in the US. Her other role is a global case management specialist, providing technical support for global country programs on prevention, diagnosis, and treatment of malaria, pneumonia, diarrhea, malnutrition, and dengue. Maddy has been with Malaria Consortium since 2011 and has served as a senior technical and training advisor for their seasonal malaria chemoprevention project since the initial project pilots began in 2013. She is a certified clinical nurse specialist in HIV/AIDS and infectious disease and a public health educator. Maddy received a Bachelor of Science from Georgetown University, an MA in Art in Japan, and completed 4 years postgraduate work in adult learning at health psychology at Capella University and the University of North Carolina. Maddy was born in Bolivia and grew up in Central America and has lived and worked in Latin America, Africa, Asia, and she's currently residing in Raleigh, North Carolina. Maddy, welcome, and please tell us more about Malaria Consortium.
Hello, everybody, and good afternoon. Thank you for being on this webinar, wherever you've come from. So yes, Malaria Consortium, like AMF, is also a top charity for GiveWell. And we've been lucky enough to have received about $200 million in funding through GiveWell for one of our biggest programs, which is the seasonal malaria chemo prevention program, which I'll tell you a little bit more about. And that's been since about 2017. But Malaria Consortium has programs in about 14 countries, both in Africa and Asia. The type of work that we do is to do evidence-based end-to-end implementation of programs. And so what that means is we start off by collaborating with local governments, national governments, ministries of health, to do planning from a national level down to a local level. We do procurement and supply chain of either treatments, diagnostics, or even bed nets. And then we do the entire supply chain throughout the delivery. We train trainers and all types of people that would be delivering a program, including supervisors and data recorders. We do community engagement, which is doing a lot of behavioral communication. We then deliver the program, and while we're delivering it, we also ensure that it's being supervised and monitored so that we have good evaluation data. We conduct surveillance and research, and then we usually report and publish. Most of our malaria programs are aimed at prevention, diagnosis, and treatment. And when you see here, I've got eradication versus elimination. So whereas we are aiming towards elimination, eradication is a little bit further off. So our strategy is to work in areas where there's high endemicity or a high stratification of high incidence in cases of malaria. We will target those to get them to lower the number of incidences of malaria as well as deaths, with the ideas that we really want to be focused, strategically focused. So just to clarify, the difference between elimination is that elimination is about interrupting the local transmission, getting to zero incidence or zero number of cases. It's exactly what we're trying to do right now with COVID-19. Eradication is more when there's a permanent reduction to zero worldwide, where there's no incidence of malaria infection in humans. And so, whereas I completely agree that we are on the right path towards elimination, and I think we can be there in a few years, at least by 2030, eradication might be a little bit more of a challenge because malaria is a tricky disease. It has a life cycle both in a mosquito as well as a human being, and so you have to be able to interrupt it in both places. In terms of the biggest barriers that we find for elimination is one is poverty and being at the last mile, which is why we try to get out there to the last mile. Most people in poor countries don't have very good primary health care. They don't have good access to care. Another big problem is having a constant supply of commodities. We often experience that certain governments have stockouts of key drugs or key test kits. There's also the emerging insecticide resistance within bed nets. And you heard AMF talk about how it's important to have these new types of bed nets so there's constant research going on to improve upon the bed nets. There's also drug resistance. We learned a couple weeks ago that artemisinin resistance, which is one of the best drugs that we have right now, has been shown to show up in East Africa, particularly in Rwanda, which is a concern because that means that it could spread and then we don't have good drugs available to treat children. I should add that our target audience is mostly children under 5 and women who are pregnant, and because they're the most vulnerable to getting malaria. Children under 5 have very weak immune systems, and so they tend to get severe malaria and die more so than adults do. And pregnant women, because of the pregnancy reduces their immune strength, they also tend to be vulnerable. Another barrier to elimination is security and political instability. I don't know how much you've been watching the news, but last week, Chad's president died, and there's been a bit of security and political instability there. Chad is one of our countries in which we work and has quite a high malaria burden. Another big barrier that you all are very familiar with, being that it was Earth Day a couple of days ago, is climate change. The vector for malaria is a mosquito, which breeds in water. And so as climates get wetter or drier, the incidence of malaria changes. And I'll talk a little bit more about that now, because one of our biggest programs is called seasonal malaria chemoprevention. And what that means is we deliver anti-malarial medicines to children between the ages of 3 months to 59 months or 5 years. They take it once a month during the rainy season, and the rainy season can vary between 4 to 5 months. But what we found is that by just giving these anti-malarial medicines, which they stay in the body for quite a long time, for about 28 days, if we give it monthly, we can significantly reduce the number of malaria cases by about 78% and also reduce the number of deaths. We have the largest seasonal malaria chemoprevention program in Africa. We're in 6 countries, and this year we plan to deliver SMC to approximately 16 million children, which is, when you think of that end-to-end delivery, it requires a lot of people and a lot of funding to do that. But fortunately, we've done some cost effectiveness studies, and we have found that it's about $4 per child per year. So it's not a lot to just save a life. $4 is pretty reasonable. I also wanted to mention that the World Health Organization came out with their E25 goal, which is to eliminate malaria in 25 additional countries by 2025. That's an ambitious goal, but I think we're on the way. The other is to let you know that there are 11 high burden, high impact malaria countries. Those are the ones we tend to focus a lot on. They're the ones where they have the highest risk, they have the highest mortality, Nigeria being at the very top. Nigeria has 25% of the world's cases of malaria. And that's where we have some of our largest programs. We're also doing bednet distribution in Nigeria. I'm going to save my point there about the implications of the new Oxford malaria vaccine, which was announced on Friday, because I saw there was a question there, and I think it might be better if we talk about it there. Yeah, I think in terms of, one of the questions was about how COVID-19 affected malaria health services in 2020. All of the modeling that we had from all the universities, as well as the World Health Organizations, predicted that COVID was going to be a disaster for healthcare and malaria in Africa. And it turned out that it wasn't as bad as we thought it was going to be. It did affect malaria services, but we managed to stay on top of it, as did many other organizations doing the kind of work that we do, by putting in strong infection prevention and control measures, training all of our community distributors to continue to do the work. We had to get additional funding to get face masks and disinfectants, and teach them about physical distancing. And it seemed to have worked quite well. We did not have any cases of COVID-19 from any of our programs that we distributed. The one feedback we got was that we were really severely strict about our rules, but it turns out that maybe that was a good idea. And then the other piece is that we're still unclear as to why COVID has not taken off in Africa. There is some speculation to that, but because there's no concrete evidence of it, I'm not going to add to that just now, because we really need to, keep our eyes on. We're definitely doing some research on that in Uganda and should be publishing something soon. And then in addition to climate change, I wanted to also say that one of the other barriers to not eliminating malaria as fast as we can is because of lack of interest. There's sort of this fatigue, that people go, oh, is that still around? And getting enough funding. We're very grateful to all of the philanthropic donors that have been generously giving to Malaria Consortium throughout these last few years, because it's really helped us to get our programs going and reach more and more children and pregnant women. And so it's just keeping people aware that yes, malaria is still around, it still exists. And our goal is to get there. And you can always visit our website. We have literally hundreds and hundreds of publications about the work that we do, because we are very researched and evidence-based. And I'll stop there, and we'll talk maybe about the Oxford vaccine and the mRNA vaccine a little bit later.
Thank you so much, Maddy. That was really fantastic. Really great to hear the level of detail around what you guys are doing as well. That's really great. Our next panelist is Alekos. He is the scientific manager of Polo GGB, which is a partner institute of Target Malaria. Before joining Polo GGB, Alekos was working at Imperial College London as a molecular biologist, where he contributed to the development of gene drives in the African malaria mosquito as a novel tool to stop malaria transmission. At Polo GGB, their role is in key in the development and testing of the gene drive technology in a confined laboratory before transferring the technology to the field. Alekos has been working for this project since 2011 and is very motivated and excited to see the great progress that Target Malaria is making in the development of a new tool that could contribute to saving millions of lives. Welcome, Alekos, and I'd love to hear more about Target Malaria.
Thank you for the introduction. It's a pleasure to be here this evening. It's evening for me, at least, to talk about what Target Malaria is doing for controlling malaria. Just a few words on what Target Malaria is and what we are. So Target Malaria is not a charity. We are a research consortium, and we include scientists like myself. I'm a molecular biologist. We have also protein engineers, medical entomologists, population biologists, and social scientists. But there's also a lot of people in Target Malaria which are advisor for risk or regulatory and even stakeholder engagement. Currently, Target Malaria is made of 11 institutions, and we have partners in Africa. There are 5 countries in Africa which are part of Target Malaria, and in Europe, where I'm based at the moment, and North America. If you can go to the next slide, please. And the objective of Target Malaria is to co-develop and share novel genetic technologies for controlling the mosquitoes that transmit malaria, which are the Anopheles mosquitoes. And we want to contribute the burden of malaria in Africa. We currently work on the Anopheles mosquitoes present in Africa, because in Africa is where the most of malaria cases and death occurs. And the technology that we are developing, it's complementary to the other methods that are currently used, like the bed nets or insecticides or the medicines. And the advantage and the promise of our technology is that it is a sustainable technology, it's cost effective, and has a long-term efficacy. And the idea behind the technology is very simple, and is that to reduce the mosquitoes that transmit malaria. So in order to control malaria, we want to reduce the number of mosquitoes in the population that transmit malaria, and therefore reducing the transmission cycles. And we want to do that using genetic modification. That's why it's a novel and innovative technology. It's never been used before for malaria. And the idea is to modify the mosquitoes genetically in order to control the population of mosquitoes. If you go to the next slide. And Target Malaria is pretty much based on 3 pillars, as we like to say. Of course, there is the science, is where I'm contributing, which is a big part of Target Malaria in developing this genetic technology. But it's not only science. We also work on stakeholder engagement. So we have people in different levels, stakeholders, going from the villages in Africa where the technology will be used, also up to the level of governments and even international organizations and the regulators that can regulate the technology. And the other part is exactly the regulatory affairs. So we work in strictly with the different regulatory agencies and bodies, also because the technology has never been used and there's still a lot of debate on how the technology can be used in the field. If you go to the next slide, please. And the basic of the technology, it's as I said, is a genetic modification of the mosquitoes, and the technology that we are developing is based on gene drive, which is a very particular type of genetic modification. If you go to the next slide, I give you a brief and simple, I hope, overview on the basic of the technology and what a gene drive is. So the idea, as I said before, is to stop malaria transmission by reducing the number of mosquitoes that can transmit malaria. If you look at the plot here on the left-hand side, the idea is what we call is a population suppression. And this is based on the release of genetically modified mosquitoes with some specific characteristics that when they are introduced into the population and they are identified here in green, they can spread through the population. And while they do so, they reduce the overall size of the whole population. Reduce the malaria transmission. And we want to reduce the population to a size so small that it can stop the malaria transmission. That doesn't mean that we need to eliminate all the mosquitoes in the population, but just to reduce to the number so that you can stop the cycle. And the way to do that is to use this gene drive technology, which is a genetic process, gene drive. And in very simple terms, it can be defined as the preferential transmission of genes from one generation to the next. That means that is a type of modification that increases in frequency over time. And this is exemplified by this picture here on the left on the right hand side. If you have a generation one, few of those gene drive mosquitoes indicated in green, and when they mate and they reproduce and they give progeny in the population, they transmit this gene drive to all of their progeny. And they do so generation after generation, and therefore they increase in frequency over time to the point that they can spread throughout the whole population. And if you, for instance, use this gene drive to target some specific characteristic of mosquitoes, for instance, you can make the female mosquito sterile, and the female mosquitoes are the only one that bite and transmit malaria, while the gene drive spread this modification to the population, making the female sterile, you can then collapse the population. And this is very effective, at least in the lab. We have very good and solid data in the lab that shows that this technology works very well. And we are in the stage that we have candidates, mosquitoes that in the lab could reach population suppression in a confined laboratory population very, very effectively. This is a very it's a sustainable technology because you release mosquitoes and then the mosquito do the work themselves to mate and reduce the population. It's very effective, it's cost effective, and it's also very, very complementary to any other technologies. It's complementary to bed nets, it's complementary to vaccines and to other interventions because you are targeting the mosquitoes directly, and actually reducing the number of mosquitoes, it also increases the effectiveness of all the other interventions. That's why we have a lot of promise and on gene drive technology, and there is a lot of interest. Yeah, thank you. You can go to the next slide. And since gene drive is based on the mating of mosquitoes to each other, this is also a very targeted approach because we can specifically modify and target few species of mosquitoes, and those are the only one that can transmit malaria to humans. So it's very specific. In Africa, in the world, there are hundreds of different types of species of mosquitoes, and we are specifically working on 3 species, which are on the genus Anopheles, which is Anopheles gambiae, Anopheles colucci, and Anopheles arabiensis. And those are the majority, they are responsible for the majority of malaria in Africa. And targeting just those 3 species, it could potentially save hundreds of thousands of lives. So this is in very simple, the approach of target malaria. If you can go to the next slide. I just want to mention our funders. So we are not a charity. We don't receive funding directly from the public like some of the other guests tonight. But we are a research consortium, so we are fully funded by, at the moment, from mainly from the Bill and Melinda Gates Foundation and also from the Open Philanthropy Project, which is an advice fund from the Silicon Valley Community Foundation. So I stop here for the moment, but I'm very happy to take any questions.
Excellent. Well, thank you so much for sharing that. It's really fascinating work. Yeah, it's a really novel approach, and I'm sure many people, this would have been the first time that they were hearing about this approach. So I'm going to kick off with just the first question to you: is where are things at in development? Like, you know, how far off do you think this is from being actually implemented in the field?
Yes, it's a very good question. So we are still at the research phase, in the sense that gene drive has not been used and released anywhere in the world yet. And we are making a lot of progress in the lab. We have now a technology that we think is very effective, at least in the lab, to stop and to reduce, to collapse a population of mosquitoes in cages in the lab. But there is still a lot to do before the technology can go from the lab to the field. And the approach that Target Malaria is using is a stepwise approach. So we go through different phases of the technology, both in terms of development and deployment. We did the first release of genetically modified mosquitoes in Africa in 2019 in Burkina Faso. That was not gene-drive mosquitoes, but was still genetically modified mosquitoes that were sterile males. And that was a very important learning step from the project. So we are going in different phases in terms of developing the complexity of the technology. And it's still a bit difficult at the moment to say exactly when gene-drive mosquito will be released. We're still working also with the government to obtain all the permits for the release. And we hope the technology can be ready to be deployed something like in 10 years time, probably, hopefully earlier, but it's difficult to say at this stage.
Yeah, excellent, thank you. At this stage, I'm going to invite both our other guests back to the stage. I'd love to hear a little bit more from both Rob and Maddy as how COVID-19 has affected your programs in 2020 and what that looks like moving forward as well.
Maddy,
Rob.
Oh, you want me to go first?
Yeah, you go ahead, Rob.
Okay. It actually had minimal impact actually on us. I suppose the two things I would point to was we had a 4-8-week delay in some of our programs. We had a nervous period where we weren't sure what ministers of health or ministries of health would do with regard to stopping nationwide net distribution programs, because inevitably they involve movement of people. Fortunately, that 2-week period ended quite quickly in 2 weeks with all ministries of health recognizing that it was important to continue with net distribution programs. And then we had between a 2 and 6 week delay to some programs starting because we were waiting, or countries were waiting for PPE to arrive. So that was really good news, because we could have been faced with a situation if COVID had really been kicking off in Africa, the numbers had been climbing steeply, that programs would have been suspended. And that would have been really very bad news for malaria control. And it would have been very bad news for people who suffer from COVID, because we know that comorbidity with COVID leads to a higher impact of COVID. So it was a sort of a hiatus or a pause for us. We also had to make some operational adjustments. We particularly like the 2-phase approach to distributing nets. In other words, a household registration phase where we gather data and establish exactly how many nets each household needs, followed some weeks later by the actual distribution, because that gives us time to review the numbers and clean information and verify information. So we had to collapse that to a contemporaneous registration plus distribution. but that was agreed by all partners, and we decided collectively as a wider team, not just AMF, but all the partners involved and ministries of health as well, that that was the right way forward. We also couldn't have colleagues traveling to Africa because obviously international travel was stopped. We all moved on to Zoom, as we've all done in the last year or so. We've all become extremely expert at Zoom. In fact, I'd say that there were advantages of that side of our work, whilst we as a team couldn't meet up as frequently as we had, because we all operate remotely at AMF. We don't have any offices, so we all work from home effectively. It did mean that there was an awful lot more contact by video, which I think all of my colleagues have found pretty fantastic, that we can actually speak to people in Africa and see them rather than in the old days we used to just talk on the telephone. The fundraising side has been strong for AMF over the last 12 months, which we've been very pleased to see, because we've got funding gaps, and so we're always in need of money, so that's been good. So in general, limited impact for us operationally, and importantly for the programs that we're involved in Africa.
Very interesting. So from Malaria Consortium's perspective, when the pandemic started to hit globally, the World Health Organization put a coalition of people who work in malaria together to decide one way or the other. Are we going to continue with essential malaria services, which would be diagnostics, treatment, and prevention? Certainly, are we going to do bed night campaigns? Are we going to do our seasonal malaria chemoprevention? Are we going to give treatment to women, antimalarials during pregnancy? And so the general consensus was, yes, we're going to do this. So we had to all sit down and decide how are we going to change our SOPs, our standard operating procedures? How do we deliver things while keeping physical distance? How do we ensure that things are disinfecting? And at the moment, at that time, we only had a certain amount of information available to us. So what we know now is quite different than what we knew then. And so there was a lot more anxiety about touching things and so forth. So we had to revise everything that we did. We went through all of our training materials, all of our job aids, and redid them in a very short period of time. Most of our staff work in either Africa or Asia. They were also on lockdown. So how do they get the programs out there as well while they're limited to being out in the field? Like Rob and AMF, we also did not travel. I haven't been to Africa since last year, February, and I usually go about 12 times a year. So that was all shut down. And I tend to train a lot of the health providers in a lot of these countries. And so now I couldn't train in person, so I had to train by Zoom, which is not the best platform to do training in, plus having to negotiate with time zones and getting up very early in the morning and having to deal with the bandwidth challenges that we had there. I think our biggest challenge more than anything, we managed to get all of that work done, but our biggest challenge was getting the PPE. There was such a high demand, it was expensive. Supply chain programs were being shut down, and so that was really quite difficult for us. But yes, we did manage to get it. So it's all of our programs that were community based continued to be community based, and we ensured that we did really specific training on what was COVID, why did we have to follow these protocols, and having to deal with a lot of the anxiety and fear of our staff. But I think right now for 2021, people are like anything, we get accustomed to our behaviors, and we're going to continue to do our programs and continue with the infection prevention control training and providing them with PPE. In terms of cost, it probably in total cost us about $5 million to ensure that we had enough PPE for everybody. I don't know if that's normal cost, and I don't know if it's because the prices were so high. We felt that that was pretty reasonable considering how many people we had to keep going at the time. So that's pretty much the biggest impact. Right now, I think there's still that element of misinformation. Conspiracy theories do spread throughout Africa and Asia, just like they do in other parts of the world through social media. So having to manage that has also been a challenge. We are doing some research in Uganda where we're looking at people who had severe malaria and COVID to see if there is a link in terms of it making it worse or better. Interestingly enough, actually, malaria can help you get better from COVID. We don't know why, but that's certainly what our findings are showing. And so we're going to do further research on that as well. It might have to do with some immune modulator that, they've always thought that maybe malaria could be sort of an immune down regulator, and that might be why it's helping with minimizing severity of COVID.
Wow, that is fascinating.
Yeah, it is.
Well, so we have a question that is relevant to all of the work that you have been doing, and this relates to the promising vaccine that might be coming out of Oxford, and just would like to hear the reflections as how it impacts your programs and how you think it fits into the mix, and just any reflections you have on that as well. So Maddy, while you're there, do you want to have your reflections?
Sure, I'd love to. So before the Oxford announcement, there had really been only one vaccine that's gone under randomized clinical trials, and that was by GSK. It was called RTSS. Didn't have very good efficacy, required several different doses, where the last dose being 18 months out was critical. If you didn't have it, you'd get zero efficacy. So it wasn't very exciting. And so now we've got this new one. It's was tested only in a small population of only 450. It's called the phase 2B trial, which is a small trial to test safety and efficacy. The children were between 5 to 17 months, and it lasted for a short period of time. They are going to start phase 3, which are usually larger vaccine studies shortly, and they're going to do it in 4 countries and have a much larger group. The vaccine that the Oxford group developed is actually quite interesting. It's very different than RTSS. I won't even begin to try and explain to you how it all works, but because it uses recombinant hepatitis B surface antigen, and it uses something that's called the protein matrix, which is very similar to the Novavax COVID vaccine, where it's just it's a protein particle that presents this antigen to the immune system. And it seems to be doing really, really well. And it seems to have very, so far, not any serious adverse events. But I do want to talk a little bit about vaccines in general, and because we're experiencing this a little bit with COVID vaccine in Africa. And that is, for vaccines to work, they've got to be effective. So 75% is pretty good for malaria. They have to be safe, so we don't want to be killing anybody or giving them some long-term illness. For the developing world, they have to be cost effective or free. So that's sometimes a challenge with all of this technology. It needs to have minimal reconstitution, so you don't want to be needing to mix with different types of things like normal saline. It has to have a good cold chain, because many of these countries have, up to 120 degrees heat. And it has to have minimal doses. So 1 or 2 doses is good. And that we should be able to have a constant supply chain and be able to train people pretty effectively. So this can always be a challenge in the developing world. It's not impossible. There are very good vaccine programs in every single country that give childhood vaccines anywhere from birth up to about 15 months, and they work really well. So that's probably where the vaccine is going to, the malaria vaccine is going to be delivered. But in terms of our programs, essentially seasonal malaria chemoprevention, when we started the trials back in 2013, the concept was this was just something to help us cover until there was a viable vaccine. And so we welcome a vaccine. I mean, if we can get these kids vaccinated and not get malaria ever again, please, yes, let's do that. So it will take time. I think we need to obviously get the results from larger clinical trials, and then it's just a matter of manpower and money, basically. But it's totally done. It's completely doable, and I think it will make a very large contribution to elimination.
Thanks, Maddy. That was really insightful. Rob, would you like to jump in?
Yeah, I mean, I think it's always great to hear news about vaccines, because unless we hear the early news of promising results, that's the start of the process. I think there are 7 phases in vaccine development. We're at stage 2 at the moment, so there are many stages to go. So I think the summary is promising. Let's hope that really good results continue, and good characteristics of the vaccine, as Maddy described, become the case. And I think we've all got a fervent hope that whether it's a vaccine or whether it's in Alekos' sort of area of gene drive technology, sometime over the next, is it going to be 5 to 10 years? Alekos talked about 10 years, that sort of time frame. We're going to be seeing something that makes a major contribution to the solution to malaria. I think we all have to want to shut up shop within our charities and close down, because if we didn't want to do that, then there would be something very wrong with what we're really aiming to achieve. So I think there's a long way to go. We're going to have to wait probably, I would suspect, for the next 2 or 3 years to roll past. I think we've all got our fingers very firmly crossed in the meantime, that the news continues to be good. And then realistically, it's going to be a sort of phased rollout. You won't find that a vaccine is found and then suddenly within a year everybody is vaccinated. It's going to take a series of years, and it depends upon the challenges of the operational side. Hopefully, funding won't be an issue, because if it's a solution, the economics are really well weighted to rolling out a vaccine or rolling out a gene drive technology solution. So really pleased, we should all be incredibly pleased to hear news about vaccine progress. We have to wait until it becomes part of the solution set.
Thanks, Rob. Alekos, would you like to add anything on that?
Yes, just very briefly, I think what Maddy and Rob said, I subscribe completely. We are all very happy if a vaccine that is proved to be effective and safe is available for malaria. The mission of Target Malaria is to have a world free of malaria. So any new tools that comes on the road is really, really welcome. And the vaccine are always usually the most amazing tool that usually we have to defeat diseases. I just want to add that, yes, for malaria, it's very complicated. The logistics sometimes to reach every country, every people. The matter of cost effectiveness also, it's very, it can be very problematic in large part of Africa. And I just want to add that for Target Malaria, it's very complementary, and even reducing the number of mosquitoes, it can even make the vaccine more effective, because if you have less incidence of malaria, it's just better for the vaccine. So even if the effectiveness of the vaccine is not 100% or 70%, if you reduce the mosquitoes, it's just even better. So I think that complementarity of the different tools and having all the tools together, I think that's what can go from elimination to eradication. And just, I think that for malaria, one single tool is not enough. Even a very good vaccine probably might not be enough alone to reach elimination, and we need to the synergy of different players, different tools, vaccine, bed nets, gene drives, and anything that can be safe and effective to fight against malaria.
Yeah, thank you. I realize we're getting very close to the end of the session. I'm just going to be launching a poll for the attendees to fill in just a short feedback poll and an opt-in if you'd like to have follow-up from any of the organizations represented today. But I have one final question, Alekos, and we've had a few questions relating to the ethics of the gene drive technology, and I just wonder if you could speak to what some of those common ethical questions are and your perspectives on them.
Yeah, thank you. It's a very good question. We always get a lot of questions about the ethics of genetic modification. I just want to say that we at Target Malaria take all those concerns very seriously. We ourselves are the first one that we question the technology, and we want to be sure that technology is not just effective but also safe. We as Target Malaria have an ethics advisory committee that deals exactly with all the ethical questions that people may have in different parts of the world, because it could be different beliefs, different cultures. So we are always very conscious and aware of the concern that people may have. We want to develop a technology that can make a sign against malaria. And within the gene drive, it's really a very powerful tool that can make a difference. So this is our aim. We are looking all possible implications of the technology in terms of the ecology and so on. And we take safety very, very seriously.
Thank you so much for that. Where we're just reaching the end of the session, Jack, I might ask if you could post the link in the chat to the EA forum post that we had, which had some questions. If anyone has any further questions, they can put some of them into that forum post. And Jack and I, we can do our best to find some of the information that these organizations already have on their websites. We'll also share it with the panelists if you do want to have a look and see what questions people didn't quite get to today. So just before we leave you, I just want to mention that we've talked about the two of the organizations here today, charities who are doing excellent work and are always in need of funding. There are a couple of ways you can give to them depending on where you live. I'm going to paste this table in the chat as well. Against Malaria Foundation has very good coverage in many countries, but some of these can help re-grant to Against Malaria, and Malaria Consortium as well as can be donated to directly, tax deductibly from a few countries. But if you can't find them, we have a table on the Giving What We Can website who can help you find where in the world to find them. On that note, I want to say a big thank you so much to our panelists today for sharing the excellent work that you're all doing. And working on such an important problem to try and relieve the burden and eventually eradicate malaria. So just on a personal note, thank you very much from me for that, as well as for your time today. Thank you all so much, and have yourselves a wonderful rest of your day, evening, wherever you are in the world.
Thank you, Luke. Thank you, everybody. Bye-bye.
Thanks. Bye.